Welcome to another episode of ANEM's Lessons from the Lab. My name is Devin Rubin. I'm a neurologist at Mayo Clinic in Jacksonville, Florida, and I'm happy to be with you again hosting another episode of Lessons from the Lab. This should be an interesting case. I have a great guest once again, as they all are, and this is someone who I've known for a long time. We actually were oral examiners for the ABEM board examination many years ago. And I'm going to get to examine him when I present him this unknown case, and I'm sure he's going to do just fine. So enjoy. Well, welcome to another episode of AANEM's Lesson from the Lab. It's a great pleasure to introduce the guest specialist here, Dr. Tony Chiodo. Dr. Chiodo is a professor of physical medicine and rehabilitation at University of Michigan, and it's wonderful to have you here. Hi, Tony.
Well, hi, Devin. Thank you so much for the invitation. This is great. This is fun.
Well, both of us are ending our Monday evening. We've had busy days, and we've both been looking forward to this. I've been looking forward to this all day. It's going to be a
Absolutely, me
highlight.
too.
So, well, I wanted to start off. Well, I guess I saw you. It hasn't been that long. I saw you at AANEM. Now it's been several weeks at the
Yeah,
meeting. Did you have a good time there?
it was great. It was great. It was a great meeting.
Did you have a highlight? Is there something that you enjoyed the most besides talking to me?
I really enjoyed the plenary. I thought the plenary was excellent. I thought that it challenged our thinking about certain things. Sometimes we get, we're really focused on taking care of individual patients and managing their problems, and of course, managing all the problems that insurance companies create for us to make it harder for us to take care of patients. And a lot of the preliminary was like kind of looking at the bigger metaverse of healthcare and how are the things that we're trying to do in neuromuscular medicine in terms of improving patients' lives and technology and advances and medications, how that impacts the greater, you know, healthcare system in terms of costs, in terms of access. I thought some of the concepts about, you know, access to care, and it's not, they presented a lot about, international access, but, certainly can think that just even in the United States, there are areas where it's much easier to get a neuromuscular specialist than other areas. Some places you have to travel hundreds of miles to find one,
Yeah.
and that's not even including getting treatment for these problems, which are can be so challenging. Some areas may not have the technology to be able to actually deliver these medications or this care. So I think it just made me think a lot about those kinds of challenges and how do we reach everyone
Yeah.
if that's at all possible.
I think we just need more neuromuscular specialists and get people. We've discussed this at different venues at the meeting, and attracting younger physicians into our field. And uh, that's part of it. But they don't see the light like we do. How much fun this is and how enjoyable this is. And there's so many other specialties, subspecialties that all we can do, I think, is keep trying to attract them.
That's true. And and the opportunities are there. We know that there are neuromuscular jobs that sit open for a long time without somebody to fill those shoes. And so
Yeah.
continuing to let folks know that we need them. This is a very interesting field. It is evolving. It's not static, where there are a lot of new things coming down the line. It's interdisciplinary. You get to work with lots of different professionals. It's both rewarding and challenging from a professional standpoint. It's
Yeah.
a great opportunity for the right person.
And the people who are in who are neuromuscular specialists in neurology and PM&R are great people too,
Oh yeah, just
which
it's always it's probably the best, it's I wanted to talk about the best part of the meeting being something that was unique about
yeah,
this meeting, but it's always feels like, we're coming home when we go to the meeting and
yeah,
we're getting together and meeting with friends and colleagues and people that we work with
yeah.
through the organization. And it's always great fun.
Yeah, and you talk about the people, and I want to share a memory and give a compliment here because I was thinking as I was preparing to have this discussion with you, I was thinking back to early on in my career, very early in my career, soon after I had been out of fellowship, I was getting involved in neuromuscular medicine and AANEM. And I think the first year that I was asked to be an examiner for the ABEM, I was paired up with you.
Oh, that's
And
right.
you probably don't remember, but I remember, and I remember being a bit anxious, not being paired with you, but being an examiner. You're anxious
Yes.
when you're getting examined, but for the first time you're an examiner, I didn't know how hard should I be? Should I be tough? Should I not be tough? And I remember being paired up with you, and I remember how well you examined, and I was inspired by that. And you
Well,
were
thanks.
calm. It was clear that you wanted the examinees to pass. We didn't want them to fail. And the way you asked questions, and I remember it calmed me down. and and I remember thinking, these are the type of people that I want to be around, during my career. So part of me being involved in AANEM, I think, has to do with you.
Well, thank you. It's that being involved in that exam was a career changing moment for me as well. I got to work with, you know, names in the field of neurology. Obviously, I'm being paired with a neurologist because there was a neurologist and physiatrist in each examination. But to be paired with these people who I read about and read their work was just an incredible pleasure.
Yeah. Do you remember if we failed or passed the examinees that we worked together?
I don't,
I
I
know,
don't,
I don't know.
I don't remember. Usually, I would guess probably pass because usually when I have a number of people who fail, that memory is usually lodged really deeply in my brain.
Yeah,
So I don't have
right.
that memory of that happening with us.
Yeah, I agree. And so anyway, this is a great segue into what I wanted to do here.
Okay,
So as you probably know, this lessons from the lab is an educational series where I kind of pick your brain, or we pick each other's brains about a case. And
okay,
so this is not an exam. This is there's no right or wrong answer. It's just to kind of see how you would approach a patient that I'm going to share with you.
okay, great.
And people will be viewing this, and people will be listening on podcasts. So I'm going to show you some slides, and we can talk through them as we discuss the case. So
Super.
you ready for it?
I am ready for it.
Okay. So this is the case. I'm going to share my screen,
Okay,
and let me just make sure you can see that. Can you see my screen?
I can see your screen.
Okay, so I'm going to read this for the people listening on podcast. So the case is a 58-year-old woman who was healthy. She had hypertension, but no other systemic medical problems. And she was referred to the EMG lab for shoulder pain and weakness. And basically, she had chronic left shoulder soreness for years. She said the pain was around her shoulder and deltoid area on the left. And she complained of weakness in lifting her arm above her head. So she said she had some difficulty kind of manipulating her arm in positions to get it above her head.
Yeah.
And the shoulder would pop at times. She felt that pop. And other than that, she didn't really have any other symptoms. So no neck pain, no other symptoms distally in her arm, nothing on the right side. And so she was seen by an orthopedist who sent her for an EMG with the question of cervical radiculopathy accounting for the pain.
Okay.
So that's the story. So, so what do you, so I'm going to pause there and just see what your thoughts are. Like what's going through your mind if you get this referral and when you're doing a clinic or EMG?
Okay. So I there's so much richness in this history that you've already presented to me, so it helps to really kind of think this through. So the fact that first of all is that this is just the left shoulder. So this isn't a bilateral problem. And because if it's a bilateral problem, it opens up a whole lot of other possibilities in terms of myopathic processes, inflammatory or otherwise, polymyalgia rheumatica would be a possibility as well. Um, Cervical myelopathy, if this is a bilateral issue. So the fact that it's focal left shoulder kind of has already narrowed my differential diagnosis significantly. Pain in the left shoulder and deltoid region, lots of, obviously we're thinking about, could it be something in the left shoulder? Is it left shoulder pathology? Could it be osteoarthritis? Could it be rotator cuff tendinopathy and or degenerative tears? Is there any AC joint issues as well that would be in the same region? Um, Certainly the difficulty in raising the left arm above her head makes you think more about rotator cuff pathology if she actually has weakness on physical exam. And then the question of, cervical radiculopathy. Are we, possibility that this could be a C5 issue given the involvement of deltoid and rotator cuff, or possibly C6 if it's just deltoid. Um, Probably not more proximal than that, although I just kind of throw this out there. A lot of times I'll have patients who come in with pain just on the top of their shoulder. And I think that something that I see in my clinical practice that a lot of people don't think about is that pain in the top of the shoulder could be an upper cervical radiculopathy, like a C4. And I see that quite often in practice, and folks who've kind of been around and have had their shoulder worked up, and it turns out it was an upper cervical radiculopathy. The EMG didn't pick it up because they were testing nerves in the arm and didn't look at anything with a C4 distribution. So just other thing, kind of a total aside, but I just thought I'd throw that in there because I find that in my clinical practice, that's been a very helpful thing to keep in mind. So
If you were, I'm going to jump in. If you just on that point, if you were evaluating in EMG C4 distribution on your needle, of course, there's no nerve conductions, but how would you do that? Is it just paraspinals or do you do other muscles?
I do paraspinals and levator.
Okay. Yeah.
Yeah,
Okay.
yeah. I'd only do diaphragm if they have respiratory symptoms as well. But I have had I had a patient in the last 6 months who had this kind of shoulder pain, but also had new onset shortness of breath, and they had neuropathic motor unit changes and reduced recruitment in their diaphragm and their levator, and then the MRI showed the profound stenosis at C3-4, and they actually had surgery and their
Huh.
shortness of breath went
Interesting.
away. So it was really pretty remarkable. So it's certainly something that you could see, but I typically don't go to the
Yeah.
diaphragm right
I guess
away in that.
I've always thought that if you had a single root, and I may be wrong, but a single root in C3, C4, C5, your diaphragm isn't really going to be affected because there's three roots that innervate the diaphragm, so there's safety. But I suppose it could be if you thought the diaphragm's equally involved, a third from each root, then maybe you could lose a third of your uh, motor units there. I guess I've never really thought of it that way.
And then you get the typical reinnervations, you get changes in the motor unit appearance, and then the recruitment will
Yeah.
drop.
Yeah.
Yeah, absolutely.
Okay, so back to this case. So there's a
Yeah.
lot going on. You're right. You said there's a lot of options here, a lot of things, the good
So
things you've listed.
she needs a, obviously a good neuromuscular skeletal examination focused on cervical spine and left shoulder.
Okay. So I'm going to give you the next piece of information here because this is what was in the chart from the orthopedist. And it was an MRI already. So this is as the patient's presenting to us of the shoulder. And there's a lot here, but marked tendinopathy, distal supraspinatus tendon, low-grade partial tearing of both bursa and articular surfaces, mild tendinopathy, distal infraspinatus tendon, no high-grade partial or full-thickness rotator cuff tear, some bursitis, mild signal in the muscle belly of the supraspinatus, suggesting muscle strain. That's how the interpretation was.
Yes,
Does that help you, or is this it? We're done?
we are not done.
Okay.
We're not done. So, also some of the things that it says it doesn't have. So, in the bottom of the findings, this is the third to last sentence, mild AC joint osteoarthritis. So, I'm thinking less that that's an issue. Of course, in the writing as well, the glenoid labrum is intact, and there isn't really any abnormality seen in the shoulder joint. So, we're not thinking glenohumeral joint problems. Yes, she has rotator cuff tendinopathy, but she shouldn't have weakness. She should have pain. And so my exam now becomes important because if she has weakness, I'm thinking it's because of a neuromuscular problem and not because of a rotator cuff problem.
Okay.
Certainly the popping in the shoulder could all be coming from the synovitis in the subacromial subbursal subdeltoid burst and the tendinopathy, but that wouldn't explain weakness. So,
Mhm.
so I think we still have we still have the possibility that this could be could be one or the other, but it also could be both.
Uh-huh.
And again, that's another really good concept. Studies have shown patients who are being sent to the EMG lab for evaluation of radiculopathy. Um, a lot of them, 15 to 20%, will have both a musculoskeletal and a neuromuscular problem going on at the same time. These
Yeah.
problems interact with each other. Um, they're both really common. Obviously, rotator cuff tendinopathy and cervical radiculopathy is common. But if you have a C5 radiculopathy and you have weakness, you're more likely to have symptomatic rotator cuff pathology than if you didn't have the radiculopathy, because the radiculopathy will change the biomechanics of the shoulder and can certainly make the rotator cuff symptomatology worse. So
Yeah.
continuing to think that it could be both. I know we try to put everything into a single diagnosis, but when you have problems that interact with each other or problems that are common, it
Right.
can be that they have both.
Yeah. And I think, yeah, relying solely on imaging isn't the best thing to do. And same with radiculopathy and lumbar spine or MRIs. And we all know that, a high frequency of the population is going to have a herniated, a bulging disc, or some stenosis on the MRI, and it may not be causing any symptoms. And
Well, absolutely, and the same with rotator cuff.
yeah, exactly.
Over the age of 50, half of patients with no shoulder pathology, no shoulder symptoms will have MRI findings of either rotator cuff tendinopathy or even rotator cuff tear.
Yeah. Right. So, okay. So if the a patient was sent to EMG for an EMG for cervical radiculopathy, this patient,
Yeah.
and you were doing your cervical radiculopathy electrodiagnostic assessment, what is that what's that for you in your lab? Just like a routine. nerve
So,
conductions and needle and needle.
it'd be nerve conductions, median and ulnar, sensory motor. Um, if the differential diagnosis included plexus, in this case, it would consider a lateral interbrachial cutaneous sensory study. Um, but without a physical exam, I'm not sure that we're really thinking that plexus is high in our thinking here. And the needle exam would be we would look through all the root distribution in the upper extremity with focus on the area that is weak. So we would really want to be focused on C5 and C6 distribution muscles.
So
And so
what are your muscles? What are your kind of go-to muscles when you're screening, just routine screening? You know, what I'm just curious, what do you like for your C7 and C5, 6 muscles?
C7 triceps and FCR, C6 um, deltoid and um, plantar teres.
Mhm,
Brachioradialis is also a good one. C5 um, biceps and infraspinatus.
mhm. And do
Uh,
you do, if you had a patient, maybe not necessarily this patient, but a patient that had neck pain, no arm symptoms, no weakness, do you do all of those muscles or do you just do like two, you know, two C7, two C6, or are you more extensive in your needle exam?
oh, I would do, the studies that were done with our colleague, Dr. Dillingham, would say to do, 6 muscles in the arm. And so I would do 6 in the arm. So I may end up doing just 1 in each distribution with
Mhm.
maybe 2 in the distribution of where most of their symptoms were. Um,
Yeah.
and
Yeah. I
if,
mean, it's not like every cases, of course, you can't put them into this set protocol. You know, I
yeah.
think,
So like for this one, CAT1, I would do the FTIH only. I wouldn't do a
yeah,
median innervated. I wouldn't do EI. I do a single triceps, and then I'd be all over C5 and 6
yeah,
and focus
yeah.
my study there.
Right. Okay. So I'm going to actually show you. So this patient was I saw a while ago, a few years ago, but this was the EMG that was done, not by me, but when I saw the patient in clinic. So this was the EMG that was done,
Okay.
and I'm going to just quickly go through this. The nerve conductions, we did a median motor, which was completely normal.
Normal.
Ulnar motor, which was normal. Green is all
Lovely.
within normal limits.
Lovely. Look at the waveform. Each perturbation of the waveform is absolutely reproduced in the distal and proximal. Every little turn is exactly the same.
Yeah, right.
That's
Yeah,
nice.
it is nice. I like it. It makes when we have great techs that do this, and it makes me happy when they're nice.
Yes,
And they like me to be happy, so I don't grumble at them.
I I doubt that you do much grumbling, Devin.
I
That's just
do.
not
I
your
don't grumble, but
personality.
I scrutinize, and they know I scrutinize. And I could even say to them, "This is how bad I am, or good I am, however you interpret it." I could say, "Well, this marker right here on this hump should be right here." If you're comparing the amplitudes, you have to
Oh,
have the two markers in the same spot. But that's just my compulsiveness.
okay. Yep.
So anyway, the motors were good, and then they did antidromics, ulnar anti. There's a big motor artifact, but here's the
Sure.
response.
Sure.
And that was fine. And a median
Lovely.
anti, that was fine.
Lovely. Yep.
And then the needle exam were these muscles. So kind of like what you said as a general screen, FDI, pronator teres, biceps, triceps, deltoid, and they were all normal.
Yes.
So that's what was done. So can we just go back and say this is the rotator, the tissue, or are you comfortable with this?
Um, no, I would do one more C5 muscles and I do paraspinals.
Okay. And this has been going on for months.
Yeah.
So would that, I guess a question, I'm not, these are not quizzes, it's just your thought process. If you have someone sent for a cervical radiculopathy and they've had symptoms, let's say for 6 months or a year, and you don't find any needle findings in the limb muscles in the distribution you're suspicious, do you find this paraspinals typically helps you?
In the cervical spine, not as much. In the lumbar spine, especially with stenosis, the paraspinals in the lumbar spine can be very helpful.
Mhm. Yeah. Is that
Yeah,
why do you think? Because it's getting the posterior ramus
exactly.
and not,
E-
yeah. Okay.
Yeah, because it's getting the posterior ramus. You know, one of the interesting things that I look for on my MRI studies of the lumbar spine is I actually want to look at the multifidus at all the levels and look for fatty replacement. That's
Mhm.
not something that's typically reported by the radiologist, but it's something that I look for to see if there has is some radiological evidence of changes related to denervation in the
I
lumbar spine.
I agree 100% with that. And I've seen many patients where you look at the lumbar spine and it's just fatty replacement or either fatty replacement or denervation. And I agree, the radiologists don't focus on that. They're looking for
Correct.
structural processes.
Yes.
Yeah.
Great.
Okay. So, okay. So, so what do we do now? I guess I guess we do. Oh, go ahead.
Well, I feel a little uneasy because I don't feel like we've done kind of the full physical exam part yet.
Okay. So you want
And
to, you've said it about 10 times and I've been holding this back. So, but this is kind of how it presented actually,
sure.
and I think we'll come back to some teaching points at the end, but this is how the patient presented to me. They had had the MRI, they had had an EMG, which this EMG,
Right.
and then I got a little more history. So I was doing a consult and it was the same history, but this actually started after a COVID vaccination.
Oh my.
And it was severe pain in the shoulder and deltoid that worsened. And then the pain improved. She did have this chronic pain in her shoulder and popping of the shoulder, but it improved. And then she started noticing weakness. So history is kind of important, right?
Right.
And her exam, and this is oh, let's go here. And her exam, so this is our motor exam, if you can see this, and this is our
Yeah.
Mayo rating scale. So for Mayo, 0 is normal strength. It's
Sure.
not the MRC. So 0 is normal,
Hmm.
and -4 is completely paralyzed.
Gotcha.
So everything was fine except the supraspinatus was about 25% weak, -1, and the infraspinatus was -3, so about 75% weak. And
Yes.
there was atrophy of the infraspinatus.
Yes.
So now what? That changes things, doesn't it?
Oh, it changes
It's
things a
amazing
lot.
what the exam does.
Well, it changes a lot. It changes your differential diagnosis in terms of the history, and and it makes the idea of looking at the infraspinatus on your EMG testing sound like a really good idea.
Yeah. So what are you thinking with this exam now? And you already have the other information.
Well, if in thinking that this came on after a COVID injection, then brachial plexitis certainly has to be in our thinking about what may be going on. I would certainly want to review how the immunization was given to be sure that there isn't any possibility of nerve plexus damage from that, but usually that causes more focal problems and axillary distribution and deltoid rather than this kind of a picture. So I think
Mhm.
more brachial plexitis would be more in my thinking.
And this nerve, that the distribution of this, do you think it's in that?
It's
when
just a
you,
suprascapular nerve.
yeah, yeah. So when you're evaluating that, and I sent the patient back to the MG lab for more studies, when you evaluate this, do you do needle separate from what I've already shown you? Do you do needle of these muscles or do you do nerve conductions or both?
With with atrophy and this much reduction for this long of a period of time, I think nerve conductions would be helpful because the motor evoked amplitude could be helpful from a prognosis standpoint in terms of thinking how much motor loss there is. So I would do both.
Okay. So yeah, so we did nerve suprascapular motor conduction studies, and this is a little hard to see, but the top is the normal side, the unaffected side. The amplitude was 10.7
Yes.
millivolts. And the left affected amplitude, this is recording from infraspinatus, was 4.1. And on the right, you can see the comparison. So the affected
Ex
side was about,
Excellent.
yeah.
Excellent finding. Yes.
And then our needle showed profuse fibrillations in the infraspinatus and supraspinatus, and no voluntary motor unit potentials were activated
Yes.
there. And I think that was all that was done. The question was suprascapular nerve. We had already done other upper
Sure.
trunk muscles, C5, 6 muscles on the
Correct.
previous study.
Correct.
So do you think this would be consistent with a suprascapular neuropathy?
Neuropathy, absolutely. Absolutely.
So here's a tougher question, and this always bothers me a little. Why do you think, or can you explain, because I'm not exactly sure I can, why there's no activation in the infraspinatus, profuse fibs, but there was a CMAP
Well,
from that muscle?
well, if the lesion is neuropraxic, then that would at least some of the fibers. I mean, clearly there's also axonal loss, but if there's neuropraxia, that certainly could cause that. The other possibility is that your stimulation point
Because we're
is
stimulating at Erb's point, right?
right,
Is that where you stimulate?
right,
Yeah.
right,
So it would have to be, I mean, I guess you could have, if you had a block,
proximal to that.
yeah, which would be
That would
strange,
be
wouldn't it?
unusual for this because then the only thing proximal that could do that would be at the C5 root level, and yet your EMG shows that that's not what we're looking at. So, um, but if
Can
it
I
was,
tell you what I think?
yeah,
Because I've thought a lot about this, and it happens,
okay,
it does happen intermittently in our lab. And I think this response is coming from some other muscle that's not supplied by the suprascapular nerve. And I have one picture here. And, you know, when we're stimulating at Erb's point, we're stimulating kind of upper
ev
trunkish, around there.
everything, yes,
And we're recording on these pictures, we're recording our recording electrodes here over the infraspinatus, but I think we're probably picking up teres minor or rhomboid or something else that's being depolarized from stimulation up here.
now
And it's just yeah.
have you ever thought in a situation like that to put a fine needle in the infraspinatus and
Yeah.
do the stimulation and see am I actually getting activation of that
Yeah.
muscle?
I think that would be the only way to really know. But
Yeah,
then it's a little hard to compare amplitudes when you're recording with a needle side to side for whatever that's worth. But I think your point's a good one, that would be the only way to know, is this truly volume conduction from somewhere else, or is something coming from that muscle?
yeah, yeah, yeah. I think those are really good thoughts.
Yeah. All right. So you think this is a Parsonage Turner syndrome type of thing?
Yes,
Yeah.
yes.
Yeah. And so what would you do anything else in terms of workup or management at this point, now that you have this information?
Well, I think in 2024, there's certainly some evidence that you can see things on MR imaging of the brachial plexus. So an MR neurogram of the plexus would be a reasonable idea.
Mhm. And when you, in your practice as a physiatrist, I imagine you see patients all the time with not all the time because it's not common, but with suprascapular neuropathies. You've probably seen many patients with this.
Yes.
And so when you see them, is it usually due to something like this, or are there other causes that just as a general question, is this the most common reason for suprascapular neuropathy in your
I think,
experience?
yeah, I think it's very common that this is the cause.
Yeah.
Yeah, and I think, and the other thing that's I think important, the point we were talking about before about being sure that this is not volume conduction. That's a really important issue because if what they really have is complete denervation, then you really need to be thinking about nerve transfers. And if
Hmm.
you're thinking about doing a nerve transfer, you got about a 6-month window.
Hmm.
And so you don't want to sit on this for a long time and only find out in an MRI that's done 9 months from now that that muscle is completely replaced by fat, and there is now no longer a nerve transfer that would work.
Yeah.
So
So
I,
do
I
you
think
think, is your point that we should, I mean, it seems to me that we should always be performing needle here because the nerve conductions may be hard to interpret.
yeah,
So if we're suspecting this, the needle is probably key. Nerve
absolutely.
conductions may be helpful, but the needle exam to look for voluntary motor unit potentials is most important.
Absolutely.
Yeah.
Absolutely.
And what about patients? I mean, I always thought suprascapular neuropathy only occurred in baseball players and volleyball players. I know they can get them, but do you see a lot
Right.
of that trauma or
We we
repetitive use?
we I see it sometimes, but I think this is a more common presentation.
Hmm. Yeah.
Yeah,
Yeah.
yeah.
Okay.
The other common, and some of it may be skewed by the referrals that I get, but the other common um, presentation for Parsonage Turner is patients with shortness of breath with diaphragm denervation.
Yeah. Yeah,
And
which can easily be overlooked. And I guess the
absolutely,
other thing, on that point, and going back way back to the beginning of the case and the patient's presentation, they had difficulty. She said she had difficulty kind of getting her arm up in the air, doing things to get her arm up. Do you think I mean, this problem obviously was contributing to that, but when you see patients that have trouble raising their arm up, is this in your differential a suprascapular neuropathy, or do you think of other nerves that, not obviously deltoid, but are there other nerves in this area that can have cause trouble getting the arm up?
I think yes, I think suprascapular and axillary are the two that we think of.
Yeah.
Absolutely, yeah.
The one I've seen people get fooled is the spinal accessory. So someone who has a spinal accessory nerve, they can have winging, but they have trouble getting their arm up too.
That's true. That's
Yeah,
true.
but usually I think that's more obvious because you'll see the shoulder hanging down, or there'll be atrophy of the trapezius.
Exactly.
So yeah.
Exactly. Yeah.
Well, there are I was just curious in preparing this for you. There are a couple good papers on, and I'm not going to go through these papers. This is not a journal club, but there was a paper from some of your colleagues you may know. I don't know if you know any of them from Michigan, Detroit, Henry Ford, and then Michigan. This was back in 2019.
Yeah.
Yeah.
Yes.
So it's interesting. This had 87 patients of suprascapular neuropathy, but not all of them were isolated. There were 57 that were isolated, and the rest had other nerve involvement. And their causes were exactly like this, either idiopathic or trauma. But I thought it was interesting that a high majority of them did have the rotator cuff tears on imaging. You can kind of see percentages here that there were a
Interesting.
lot of them. Yeah,
There were a lot of them.
yeah. And then and their outcome, I believe, when they looked at the outcome, many of them actually it might be the next paper, which was from Mayo. Some of the Mayo people, and it basically found the same thing as the other paper, that they had about 60 patients, and most of them were either trauma or brachial neuritis, just like you said. But
Right.
their outcome was pretty good, especially the brachial neuritis. Many of them had recovery, as we think of in parsonage Turner, that there often is a fairly good recovery.
Good.
So, so would you want to know in this patient anything else in their history when you see these patients? That might be really interesting, besides getting a COVID vaccine and this happening.
I mean, I mean, the other, obviously the other triggers or any other, immunological stressor. So surgery and or procedures or other trauma are all things that we think about.
Yeah. And this is kind of a what am I thinking? Because I already know the answer to this, but she had her in her history when she was 16 years old, she had the flu and developed a paralyzed vocal cord that lasted about 6 months and recovered. And then when she was in her early 20s, she again had the flu, developed severe nerve pain, and as that subsided, she had a winged scapula that took about 6 months to improve.
Isn't that interesting?
Yeah,
This is not her first rodeo with this.
no, no. And so, for me, when I see this, and I don't know if you've seen patients with recurrences, especially at a young age, but I think of inherited hereditary neuralgic amyotrophy.
Sure.
So
Sure.
I offered her genetic testing to see, because there is the SEP9 gene that's been associated with it. She didn't want to do it because it wouldn't change anything.
Right.
Um,
Right.
so yeah, it's interesting when they have multiple episodes, particularly when they're young.
Yeah. And I've seen some patients who presented who've had multiple, and it could involve, um, interinterosseous in one side, and then on the other side, they'll get a hemidiaphragm.
Yeah. Yeah. I had a patient just 2 weeks ago. I'm going to stop sharing it. 2 weeks
Sure.
ago is a 20-ish-year-old guy who had 3 episodes in the last 2 years, two on one side, one on the other, kind of like this scapular winging, deltoid weakness, but all within two of them were triggered by a flu and one was just not triggered. So I wonder if he has a genetic predisposition too.
Sure.
Some
Sure.
of those hereditary neuralgic amyotrophy have hypotelorism. I don't know if you were familiar with that. They have
No.
the orbital are closer together, and I never know how to diagnose hypotelorism. So I was talking about the other day with a colleague, because I usually just look at the person and go, well, their eyes look a little close or they don't, but there's actually reference values for radiology reference values for intraorbital. I think it's the lateral orbit distances, and if they're in the fifth percentile of that, then the lower limit, then that is what hypotelorism is, something like that.
So the recommendation would be to get a skull X-ray.
If you wanted to diagnose hypotelorism, yeah.
That's amazing. No, I have not, I was not aware of that. That's a great tidbit.
Yeah. So anyway, I mean, this I think your thoughts aligned with what I was thinking, and I guess it sounds like there's a few instructive points here that, well, give me one or two instructive points that you think of this case.
Well, history. You- You've 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 got to take a good thorough history, because that really changed the entire differential diagnosis. Um, The physical exam was critical because it really isolated down where we were thinking the problem was located.
Yeah.
And then, when you're doing your needle exam, choose wisely.
Yeah. Those would be my take home points too. I mean, I think I would just expand that history, exam, like you said, but also for anyone who's focused on electrodiagnosis, who's doing EMGs, who's working in an EMG lab, I think it's also imperative to do your own exam. And I
Yes.
always tell this to our residents, if one of my neuromuscular colleagues sees a patient, sends them to the EMG lab, and I'm working in the EMG lab, I still re-examine the patient. I don't just rely on their exam, even though they're outstanding neuromuscular physicians, because we may pick up something that was overlooked, or we picked it up in a subtle different way. And so it's so important to examine the patient before we decide what muscles we're going to put needles in.
Absolutely.
Yeah.
Good point. Really good
So,
point.
and then I think the other point with and kind of your great differential at the very beginning, the first question, when people have shoulder disease, shoulder symptoms, don't rely on the imaging. Don't just think this is shoulder. That person could be weak in external rotation a little bit, or because of pain, because of the rotator cuff, but think out of the box and think about all these possibilities.
Absolutely.
Yeah.
It's great. What a great case.
Yeah, well, a great case for a great guy. So I
Right.
was saving this one for you.
It just stimulated a lot of discussion, a lot of good thought.
Yeah. Well, if I was examining you on the ABM oral exam, you would get an A+ slam dunk pass.
Well, thank you. I appreciate it.
So, well, Tony, I do appreciate you taking the time of taking your evening to talk and go through this case. I know the people who watch this, who listen to this on podcasts, will learn a great deal. And it's always a pleasure to see you.
It's always a pleasure to work with you. And this is I have watched some of your podcasts, and I always thought that they were so instructional. And I know why. You need a good host, and
Oh,
and
well,
you're a great host. So thank you so
it's
much.
thank you, and I think it's all the guests, but it's teamwork.
Yes, sir.
So, all right, take care.
All
Hope
right.
to see you soon. Bye
You
bye.
bet. Take care of yourself.
Well, as expected, he certainly passed. Dr. Chiodo was outstanding. I think he had some very important and useful instructional points. And he said right at the beginning, it would be of importance to examine the patient. And, that seems very simple. It seems like an obvious thing that we do all the time, but a good, careful neuromuscular examination is really important in not only defining the differential diagnosis, but in helping you determine what you need to do in the EMG laboratory to try to arrive at the correct diagnosis. And it's easy to get caught up in ancillary results, MRIs and X-rays and other tests, to kind of ignore the actual diagnosis and focus in on something else. But it's important to take all of the information, but use your clinical judgment first and foremost. And these mononeuropathies, suprascapular mononeuropathies, are not very common. We don't see them as often as many of the other upper extremity mononeuropathies. So it's important to consider it in the context of someone who complains of shoulder pain and shoulder weakness. So hopefully you've learned from this. Hopefully you've enjoyed the conversation. And I look forward to seeing you next time. Bye-bye.